Welcome to the deep dive. If you're maybe prepping for a meeting or trying to get up to speed on a really complex field, or honestly just want a solid understanding of something foundational to modern healthcare, well, you're in the right place. Let's kick off with a statistic. It tells you just how vital this profession is. Think about this. For over 20 years, 1999 to 2020, Gallup asked Americans, which professions do you trust the most?
And nurses were consistently at the top.
Every single year, except one.
Right, 2001. That was firefighters, understandable.
Exactly. But that consistency across all demographics is almost unheard of in public life. That level of trust is really something.
It really is.
So today we're really digging into the evolution of nursing. We've got sources that take us way back, from Florence Nightingale's work in the 19th century right up to today's global health policies, and some pretty urgent workforce forecasts. Our mission for you listening is to give you a fast but thorough grasp of what makes nursing so powerful, why it's so highly regulated, and how specialized it's become. It goes way beyond that basic idea of just patient care.
That's absolutely right.
Yeah.
And we're not just, sketching out a timeline of caregiving.
Yeah.
We're going deep into the infrastructure, the core principles, the, frankly, fierce legislative fights for recognition, the specific scientific models that actually define how nurses practice, and the economic forces, some might surprise you, that shaped nurses into the assisting critical professionals they are today.
We want to show you the science behind that trust.
Exactly. Okay, let's unpack this.
Okay, so when we talk about the roots of nursing, we have to acknowledge there's this huge history of caregiving that came before any formal profession.
Absolutely. Often invisible work.
Right. Our sources show that before, say, the mid-1800s, care happened, of course, but it was mostly families, wives, mothers, sometimes hired handmaidens.
And it was seen as what? A domestic duty. A moral thing.
Yeah, often without much respect. The women doing it were sometimes viewed almost like servants, not skilled providers.
And that informality, it meant the quality of care was all over the place.
Totally inconsistent.
But what's interesting, even in the U.S., before the Crimean War really put nursing on the global map, there were these small, early attempts at systematic training.
Like Valentine Seaman.
Exactly. Back in 1798 in New York. He was a physician who set up specific lectures for nurses caring for maternity patients.
So trying to standardize skills where the stakes were incredibly high.
Life or death, literally. And then you see things building in the early 19th century.
The Nurse Society of Philadelphia.
Right. They trained women specifically for childbirth and postpartum care. And the founder, Dr. Joseph Warrington, he even wrote a guide, the Nurse's Guide.
Establishing early home care practices formally.
Yes. So the idea of specialized knowledge, written down, structured practice, it was already bubbling up.
But it needed a catalyst.
It needed a global conflict and, frankly, an extraordinary leader to pull it all together. And that was Florence Nightingale.
She's rightly seen as the founder of modern nursing.
She captured the public's imagination because she got results. When she took that group of female nurses to Crimea in October 1854, the mission was clear. Bring organized nursing to the British soldiers.
And here's the bit that often gets overlooked. She wasn't just the lady with the lamp. She was a data whiz, a pioneering statistician.
Absolutely. She got there and saw immediately soldiers weren't just dying from battle wounds. They were dying from disease.
Filth, lack of sanitation, poor diet.
The whole environment was lethal.
Mm-hmm.
And the medical system was, overwhelmed and disorganized.
So she started collecting data meticulously.
Yes. And using statistical models, she even developed a type of pie chart, the coxcomb diagram, to show the brass what was happening. She demonstrated that simple interventions could save lives.
Simple but profound, not complex surgery.
No. It was about the environment. Clean air, clean water, better food, like giving soldiers fruit to prevent scurvy, basic public health.
And the results were staggering. She showed that these changes dropped the mortality rate from a shocking 60%.
Down to just 2.2%.
That's unbelievable. The evidence was just undeniable.
Completely irrefutable. And that evidence, that became the foundation for a new profession.
So when she came back,
she used her fame, her public standing, to establish the first proper nursing school in the world in 1860.
And that was the turning point. Nurses became an educated, professional workforce.
With their own distinct body of knowledge focused on observation, environment, holistic care. Separate from, though working alongside, doctors.
And the textbook for that school, her own book from 1859, Notes on Nursing.
Which wasn't a medical text at all.
No, it was a guide to creating a healing environment, ventilation, light, noise, meticulous observation.
And confidentiality. She was adamant. A nurse should never answer questions about her sick except to those who have a right to ask them. That's a core principle right there.
So this model observation, education, environment, it travels across the Atlantic pretty quickly.
It does. The Bellevue Training School in New York City, 1873. That was the first U.S. school founded directly on Nightingale's principles.
Sometimes called the Bellevue system.
Right. A huge leap from the old sort of haphazard apprenticeships.
But as the profession was taking shape, it immediately hit barriers, especially around race in the U.S.
Oh, absolutely. You see crucial milestones like Howard University opening its nursing program in 1892.
Which was huge, bringing nursing into the university setting. A fight that, honestly, continues in some ways today.
It really does. And you absolutely have to talk about Providence Hospital in Chicago, also founded in 1892.
A direct response to racism.
Yes. It was created specifically because African-American women were being denied entry into other nursing schools. It was the first training opportunity for black nurses.
So the fight for professional respect and the fight for civil rights were linked right from the beginning.
Deeply intertwined. You can't separate them.
Okay, let's also track how nursing started moving beyond hospitals pretty early on. Industrial nursing.
Yeah, the Vermont Marble Company hired a trained nurse back in 1895, mostly for home care, for sick workers initially.
But it was slow to catch on at first.
Very slow. Only about 66 companies had nurses by 1910.
But then things changed dramatically.
World War I was a major driver. Suddenly you jumped to 871 industries using nurses by 1919. But the other big thing was policy.
Workmen's compensation laws.
Exactly. Suddenly, employers had a strong financial reason to prevent injuries, not just treat them after the fact.
Ah, so that changed the job entirely.
It really did. Industrial nurses shifted from primarily home care after an injury to working on-site before an injury, prevention, safety checks, record keeping, immediate treatment in factory offices.
They became part of the company's bottom line by reducing those compensation claims.
Precisely, making a direct economic case for their value.
And we can't talk about early nursing without mentioning leadership during conflicts. Dorothea Dix.
Superintendent of Army nurses during the Civil War. Not just a caregiver, a major organizer, a logistician. She was honored with 2 flags for her leadership.
An incredible figure. And Clara Barton, of course.
Founder of the American Red Cross. She showed that nursing skills assessment, organization, rapid response could translate to leading global humanitarian efforts.
So looking back at that whole arc, Nightingale science, the fight for inclusive institutions like Provident, the economic reality of industrial nursing, it's clear. The push for professional respect immediately became a push for standards, for legal recognition, for authority.
Absolutely. Okay, let's unpack this. The fight for professional respect quickly translated into a fight for standards and legal authority. And that push for legislation, for standards, it was critical. As more trained nurses emerged in the late 1800s, they knew they couldn't just rely on, goodwill.
They needed legal backing to protect the public, sure, but also to protect their own professional standards.
Exactly. So they started organizing.
Yeah.
National.
Which led to the big organizations we still have today. The American Society of Superintendents of Training Schools.
Which became the National League of Nursing Education, focused on the curriculum side.
And the associated alumni.
That became the American Nurses Association, the ANA, focused on advocacy, standards, and crucially, licensure.
And they immediately started pushing states for registration and standardized training, which must have been a huge challenge.
A massive political lift, especially when most women couldn't even vote yet.
Right. But they succeeded. North Carolina was first in 1903.
Mandating graduation from an approved school and registration with the state board. That was the model.
And by 1921, just 18 years later,
all 48 states had similar laws. Standardized training, licensure. That's when the title Registered Professional Nurse, RN, really became legally secured.
That's incredible progress in a short time. Really shows the power of organized advocacy.
It does. And you saw similar professionalization happening in government service too. Dr. Anita Newcomb-McGee.
She pushed for the Army Nurse Corps.
Yes. Successfully lobbied for legislation to make the ANC a permanent unit, formalizing nurses' status within the military structure.
Okay, so let's jump ahead. How does the profession define itself today? We've got state nurse practice acts, individual hospital policies, federal rules.
And the ANA plays a huge role. They published 2 key documents.
The Code of Ethics for Nurses.
which provides the ethical framework,
Yeah.
and nursing, scope and standards of practice.
That's the one that lays out the who, what, where, when, why, and how.
Exactly. And it codifies the core critical thinking model, the nursing process.
Let's list those steps because they really are the backbone. Assessment,
Gathering data, diagnosis,
identifying the patient's response, outcomes identification,
setting goals, planning,
deciding interventions, implementation,
doing the interventions, and evaluation.
seeing if it worked.
Right. And it's vital we pause on diagnosis.
Okay.
In nursing, it's different from a medical diagnosis. A doctor diagnoses the disease, like pneumonia. A nurse diagnoses the patient's response to that disease. So maybe impaired gas exchange because of the pneumonia, or acute pain, or risk for falls.
Okay. It's focused on the human experience, the functional impact.
Precisely. The holistic needs, not just the pathology.
And doing that process well requires certain traits, what the sources call professionalism.
Yeah, it's described as multidimensional dynamic.
Yeah.
It's about knowledge, attitudes, and behaviors all rolled together.
And there's even a scale for it, Hall's inventory.
Right. It identifies 5 key things: a strong sense of calling to nursing, a belief in public service, using professional organizations for guidance, a commitment to self-regulation, and autonomy, making independent judgments within your scope.
It's like a whole ethical ecosystem guiding practice.
Yeah, it really is. And that focus on ethics leads directly to some critical legal duties, especially privacy.
Confidentiality is huge. API, the Health Insurance Portability and Accountability Act of 1996.
API exists to protect identifiable health information. PHI, protected health information.
And there are 2 main parts people should know.
Yes, the privacy rule about limiting use and disclosure, and the security rule setting standards for protecting electronic PHI. But the key is, this protection isn't just for records. It's for everything shared verbally, too.
Which feels even more relevant now with technology everywhere, social media.
Oh, definitely. The ANA has clear guidelines. You absolutely cannot share any identifiable patient info online, period, even if you think it's anonymous.
And there's a subtler point, too, about boundaries.
Yes. They warn that online contact with patients, even former patients, can easily blur professional lines, that blurring itself could potentially violate the standard of care.
Okay, standard of care. That ties into legal liability, right? Negligence versus malpractice.
Exactly. Negligence is simpler, basically, not acting with reasonable care, what any prudent person would do.
Yeah.
Malpractice is more specific to professionals. It means deviating from the established professional standard of care for that field.
So, failing in your specific duty as a nurse?
Right. And proving it legally is complex. You need to show duty, breach of that duty, that the harm was foreseeable, that the breach caused the injury, and that there were actual damages. It's a high bar.
Which brings us back to the sort of philosophical core. Nursing as both art and science.
Yes. Integrated. It's not one or the other. This idea is captured in Carper's 4 fundamental patterns of knowing.
Okay, let's break those down because this is important.
It often gets simplified. So first is empirics.
Yeah.
That's the science bit: anatomy, physiology, pharmacology, research evidence.
Hard facts.
Right. Then there's aesthetics. This is the art of nursing.
How so?
It's that ability to grasp the whole situation the patient's experience, intuitively knowing the right timing for something, the compassionate presence you bring. It's harder to measure, but crucial.
Okay. Then personal knowledge.
Yeah, it's the interpersonal skill. Using yourself therapeutically, building rapport, really listening, connecting with the patient as a unique individual, not just a diagnosis.
Understanding the person behind the illness.
Exactly. And finally, ethics, the moral compass, knowing right from wrong, dealing with moral dilemmas, advocating for the patient's rights and dignity.
So a professional nurse is constantly weaving all 4 together.
Constantly. And underpinning all of it is caring.
Which isn't just being nice.
No. It's empathy, actively working to alleviate suffering, yes, with medicine, but also through human connection, compassionate presence, touch, helping manage emotions.
And this philosophy extends globally.
It does. The International Council of Nurses, the ICN, has a powerful definition. Nursing is dedicated to everyone's right to the best possible health, committed to social justice, working for a better future for humanity.
Wow, that's a broad mandate.
It is. And the ICN highlights 2 key concepts now: cultural safety.
Making sure the person receiving care feels safe from racism or discrimination.
Yes, genuinely safe, not just cultural competence, but safety from the patient's perspective. And people-centered care.
Which is different from person-centered.
Slightly broader. It emphasizes including the family, the community, the cultural context in care planning. It means nursing by definition, has to be involved in global health equity. What's fascinating here is how Nightingale's core values of observation and environment are still codified in modern ethical and scientific standards.
Okay, so we have the strong ethical and legal foundation. Now let's look at the different roles and how people actually get into nursing. It's definitely tiered.
It is very structured, recognizing different levels of skill and responsibility.
So first step, maybe, the licensed practical nurse, or LPN, sometimes called LVN, licensed vocational nurse.
Right, that typically involves a focused one-year program. Then you have to pass the NCLEHPN exam. LPNs do vital work, but usually under the supervision of an RN or a physician.
Got it. Then the registered nurse, the RN. Several ways to get there.
Traditionally, three main paths: the 2-year associate degree, the ADN, the 4-year Bachelor of Science in Nursing, the BSN, or the older hospital-based diploma programs, usually 3 years.
But regardless of the path.
You must graduate from a state-approved school and pass the big exam, the NCLEX RN.
Okay. And then there's another level above RN.
Yes, the Advanced Practice Registered Nurse, or APRN. This requires graduate education, a master's, MSN, or a doctorate, DNP, and then specialized certification.
And who falls under the APRN umbrella?
4 main categories: nurse practitioners, NPs, clinical nurse specialists, CNSs, certified registered nurse anesthetists, CRNAs, and certified nurse midwives, CNMs.
And the key difference for APRNs is their scope of practice.
Exactly. They have expanded roles. They're trained to diagnose illnesses, order and interpret tests, prescribe medications and treatments.
But their exact authority varies.
It does. It's defined by state law. How much autonomy they have, whether they need physician oversight, that's a major area of ongoing policy debate and advocacy by nursing organizations.
Right. Now, about those exams, the NCLEX, they sound pretty intense.
They are rigorous gatekeepers. They're computer adaptive.
Meaning?
The test adjusts the difficulty based on your answers. If you get one right, the next one might be harder. Get it wrong, maybe a bit easier. It hones in on your precise level of competency.
And they're long. The RN exam can be up to 265 questions, 6 hours.
That's right. It's designed to be thorough.
And the exam itself is changing. The next generation NCLEX.
Yes, expected around 2023. The big shift is focusing less on just recalling facts and more on testing actual clinical judgment.
Decision-making ability.
Exactly. It uses what they call the clinical judgment measurement model.
So test takers will see new kinds of questions, new terminology.
They will. Questions will ask them to do things like recognize cues in patient data, analyze cues to figure out what they mean, create a hypothesis about the problem, and decide how to take actions.
It sounds like it mirrors real-world nursing more closely.
That's the goal, to simulate that fast-paced, complex thinking needed at the bedside or in the clinic.
And that level of judgment is crucial because nurses, especially RNs, often act as coordinators, right?
Absolutely. They work in so many settings over 30 different types. They're often the ones pulling together the pieces, communicating between different specialists, ensuring nothing falls through the cracks, managing care across the whole team.
Let's talk about that team. Interprofessional collaboration is key. Nurses work closely with allied health pros, like physical therapists, PTs.
Right. PTs focus on the big movements, strength, mobility, walking, how to use crutches or walkers safely, gross motor function.
Okay. And how does that differ from occupational therapists, OTs?
OTs focus more on fine motor skills and function needed for daily life activities of daily living, ADLs.
Like bathing, dressing, cooking.
Exactly. OTs do things like home safety checks, recommend adaptive tools, maybe a long-handled grabber, or special utensils or ways to get socks on easier. It's about independence in those daily tasks.
A subtle but important difference.
Very. And then you have other essential team members, dietitians.
Crucial for nutrition. Assessing needs, planning special therapeutic diets, or just ensuring balanced regular diets for recovery.
And pharmacists. Can't forget them.
Absolutely vital for medication safety. Checking prescriptions, dispensing meds accurately, but also counseling patients on how to use them, side effects, potential interactions.
It's a huge collaborative safety net, preventing errors.
Now, looking at specialized roles within nursing itself, advanced practice is growing fast.
Phenomenally fast. The sources project the NP workforce, nurse practitioners, will more than double between 2016 and 2030. That's nearly 7% growth per year.
Wow. And why such rapid growth?
It's meeting a massive need. APRNs are essential for tackling projected physician shortages, especially in primary care.
And they often work in underserved areas.
Yes, NPs are statistically much more likely to practice in rural areas and places with limited access to care compared to physicians. They're directly addressing those geographic health gaps.
And beyond APRNs, there are many specialized RN roles, too.
Oh, absolutely. Psych and mental health nurses, school nurses doing vital work with kids, rehabilitation nurses helping patients recover function after major injuries or illnesses. The list is long.
Which kind of brings us back to the core of specialized care. There's that historical point about ICUs, intensive care units.
Right, back in the 1950s when ICUs were first developing, the realization was that they were organized primarily around the need for constant nursing observation and care, even more than the new machines like ventilators.
It wasn't just the technology.
No.
Mm.
Which led to that famous line from Donna Days, nursing is what is intensive in intensive care. It's the specialized knowledge, the continuous assessment and judgment of the nurse that's the truly intensive part.
Okay, let's shift to the present day. The nursing workforce has faced enormous challenges, especially with the COVID-19 pandemic.
A huge shock to the system. In 2021, the U.S. RN workforce saw its biggest single-year drop since 1980. Over 100,000 nurses left the workforce.
That's a staggering number. Has there been any recovery?
Thankfully, yes. Data up to 2023 shows growth picking up again. Interestingly, it's being led by younger RNs, under 35.
Okay.
Their numbers grew over 8%, and also, significantly, by male RNs, their numbers jumped over 14%.
So the profession is getting younger and more diverse, at least in terms of gender.
It seems so. But there's another big trend, where nurses are working.
A shift away from hospitals.
Yes, pre-pandemic, about 60% of RNs worked in hospitals. That dropped to under 58% afterwards.
Why the shift?
The sources are clear. This drop was almost entirely among RNs over 40. Experienced nurses seem to be moving out of the high-stress hospital environment.
Where are they going? Ambulatory care? Public health?
Exactly. Clinics, schools, home health, teaching potentially less physically demanding or stressful settings.
Which forces us to look at the underlying pressures, right? The structural economic forces that have been shaping nursing for a long time.
Absolutely. Our sources trace this back nearly a century to what they call the formal subsumption of nursing labor to capital.
Okay, let's break that down. Subsumption of labor to capital, what does that mean in practice?
It basically started with the rise of private health insurance, like Blue Cross in the 1920s and 30s. Suddenly, hospitals weren't just charities or community services. They became businesses needing to manage costs and generate revenue.
So nursing work started being measured and managed based on finances, not just patient needs.
Increasingly, yes. Efficiency, cost containment, these became major drivers, impacting staffing levels, workload, the pace of work.
And this led to applying industrial models to hospitals. Taylorism, Fordism.
The 1930s, yes. This resulted in something called functional nursing.
Functional nursing, like an assembly line.
Pretty much. Care got broken down into discrete tasks. One nurse might do all the temperature checks on the unit, another does all the medications, another all the baths. Very task-oriented.
With time and motion studies, like in a factory.
Exactly like in a factory. The goal was speed, efficiency. But the big downside was fragmented care.
No single nurse really knew the whole patient.
Right, which impacted quality and, frankly, nurse satisfaction. It was dehumanizing in some ways.
Is there a modern version of this efficiency drive?
There is. It's called lean healthcare, inspired by the Toyota production system.
Toyota, like the car company.
The very same. Lean focuses intensely on eliminating waste, anything that doesn't add direct value for the customer, who in this case is the patient.
So things like waiting times, unnecessary movement, duplicated effort.
Exactly. It involves continuous improvement cycles, sometimes called Kaizen events, where staff identify and try to fix inefficiencies.
And this is used widely.
Globally. In the British NHS, in major U.S. systems like Virginia Mason, the goal is admirable: improve quality, reduce costs, but the relentless pressure to eliminate waste can sometimes translate into pressure on staffing, making nurses feel like they have to optimize every single second, which can contribute to burnout.
This pressure, combined with educational requirements, creates problems for some nurses, doesn't it? Like diploma nurses.
It does, both internationally, say in places like Saudi Arabia, and even for associate degree nurses here in the U.S., they often face discrimination. They might be passed over for promotions, excluded from specialized training, and constantly face the uncertainty of whether regulations will change to require a BSN for all RNs.
So experienced nurses might be stuck.
Potentially. The real issue is the lack of good, flexible bridging programs, ways for these experienced nurses to get their BSN that truly value their years of clinical practice. Without accessible pathways, institutions risk losing them entirely.
Which we can't afford, especially considering the future needs.
Exactly. This ties directly back to nurses being agents of health equity. We have an aging population in the U.S. All baby boomers will be over 65 by 2030.
Which means more complex, chronic health conditions.
A massive strain on the system.
Ah.
And nurses are essential to filling the gaps. We're looking at a huge projected shortage of primary care physicians, potentially over 55,000 by 2033.
And NPs are stepping into that void, particularly in underserved areas.
They are, which means nurses absolutely have to be equipped to deal with the social determinants of health, SDOH.
Things beyond the clinic walls. Housing, food security, transportation.
Yes. Because clinical care doesn't mean much if the patient can't afford their meds, or doesn't have a safe place to live, or can't get to their appointments. Addressing these social needs is becoming central to nursing practice.
And to do that effectively, the workforce needs to reflect the population.
Absolutely. We need more diversity in nursing. We need to actively address structural racism within healthcare and the profession itself. And nurses need to be shaping the policies that impact these determinants.
Which raises a question, if nurses are so central, why aren't they already dominating health policy discussions?
That's a great question. Campaigns like Nursing Now highlight this. Nurses need to be influential at all levels. But our sources suggest medical research often gets more traction in policy.
Why? Because it's more focused on specific clinical outcomes.
Potentially. It might be seen as more directly tied to measurable results. Nurses bring a more holistic perspective, which is vital, but may be harder to translate into quick policy soundbites.
So nurses need better ways to package their knowledge, stronger research networks.
Exactly. Coordinated research, turning their expertise into clear, evidence-based policy briefs that decision-makers can act on, leveraging their unique insights from the front lines.
And history shows they can be powerful advocates. Sister John Gabriel Ryan in the 1930s.
A great example, she used her position and expertise in hospital administration to fight legislation she saw as dangerous, like letting non-physicians practice unsupervised in hospitals. She knew the system and used that knowledge politically.
And the desegregation fight in North Carolina.
Also fascinating, African-American nurses in the NCSNA used careful incremental strategies. Small, deliberate steps to gain visibility and rhetorical power within the white-dominated association. They knew gaining that platform was key to advocating for their community later. It was a very strategic approach.
So today, that advocacy continues, focusing on human rights, access to care, global goals like universal health coverage.
And focusing inward, too.
Yeah.
On the well-being of nurses themselves.
Burnout, moral distress, long hours, dealing with structural issues.
Because you can't have quality patient care without healthy, supported nurses. The two are inextricably linked. #tag outro.
So what does this all mean? We've really covered a lot of ground here, from Florence Nightingale bringing data and science to the forefront.
That foundational shift.
Through that long, organized struggle for legal recognition, professional standards, led by groups like the ANA.
Yeah, securing the RN title, setting up the different educational paths, LPN, RN, APRN.
Right, leading us to today's complex reality. Nurses aren't just caregivers at the bedside. They're absolutely critical professionals dealing with huge systemic issues.
Yeah, we've seen how they're vital for filling physician shortages, especially in rural areas, how they grapple with the impact of industrial efficiency models like functional nursing or lean healthcare in their daily work.
And how they're increasingly focused on tackling those deep health inequities, the social determinants of health. Their scope is just immense.
It really is. And that global definition of nursing we talked about from the ICN.
That it's about working toward a better future for humanity.
Exactly. Which explicitly includes things like protecting the environment, tackling climate change issues that profoundly impact health.
So the work isn't just in the hospital room or the clinic.
No. Perhaps the most important work a nurse does uses all that knowledge, the empirical, the aesthetic, the personal, the ethical, gained from those intimate patient encounters.
To then mobilize resources, advocate for change, redesign systems
Right.
for broader global health.
Precisely. So maybe the final thought for you, the listener, is this. Thinking about that vast scope, where might you look next to see nurses actively fighting for a more just, more sustainable future? In what specific policy arena are they making their voices heard right now?
Something to think about.
Thank you for joining us for this deep dive.
Until next time.